Okay, we seem to have quite a few people on board. Hopefully we have all our programs represented. I'm really thrilled that every program has registered to be part of this today. That is all the new grantees. So thank you all so much. I guess I'll kick things off by introducing myself. I'm Brian Stetton. I'm the Policy Director for the Treatment Advocacy Center. We've been in personal contact, direct contact with some of you and others with just a little bit by email, but as I hope everyone's aware, we are an organization that has been working for a long time to make AOT a reality all over this country. We've been very involved in getting laws passed in state legislatures to make AOT possible, and in recent years have really kind of shifted our focus more to the local level and actually getting AOT programs implemented in local communities to make use of the powers that those laws and the opportunities those laws create for local mental health systems to do a much better job of serving people with severe mental illness who have difficulty engaging with treatment. So we are all really delighted to have you all as partners on this journey. The SAMHSA grant program that you all are a part of is something that kind of began as a glint in our eyes. We had the idea back in 2015 that if we could just take away the excuse that so many mental health systems give us of why they can't do AOT because they don't have the funds to get it started, we could maybe really have a breakthrough in implementation. And I think it's really worked out that way with our first round of grantees. You know, this is not a huge program, but we did lobby Congress to create the SAMHSA program that you all are a part of now. And that handful of initial grantees, I'm delighted that we have a few of them to join us today, have really done amazing things. And the report to Congress on how much outcomes have been improved for people in terms of helping them avoid hospitalization and arrest have certainly attracted lots of attention, lots of notice, and has led to many of the mental health systems surrounding those communities that had that first round of grants saying, hey, how do we get in on this? So that's exactly what we were hoping is going to happen with you, and I'm very confident is going to happen with your grants. And as we like to say, we feel very much invested in your success. We feel like we're all kind of partners in this pioneering journey we are undertaking to make AOT a kind of a routine tool in the toolbox for every public mental health system. So just can't express enough our gratitude to all of you for being part of this. My own background in this, I'm an attorney. I've been working on this issue for about 20 years now, starting in my work as an assistant attorney general in New York and getting AOT enacted there, something called Kendra's Law, which is, I'm happy to say, it proved to serve as a model to many of the state laws that have come on board since. And my own kind of expertise that I hope to share with you all in the work we do as partners is to kind of help develop the legal and judicial aspects of your program, to work with your judges and lawyers who are in court, obtaining the court orders and making the process work for everybody, most especially the participants, who we hope will get kind of a black robe effect from developing relationship with the judge. So we have assembled a TAC, or kind of a real dream team, in that we have other areas of expertise covered in my two colleagues, who I'm going to ask to just introduce themselves very quickly now. And I'll turn first to Amy Lukes.
Sorry about that. Hi, I'm Amy Lukes. I am a clinical social worker. I have experience in a number of evidence-based practices that you may be implementing, including ACT, individual disorder treatment, supported employment, housing first, and I'm so excited to be here with you. Oh, I forgot. I've also been a part of implementing AOT. So again, to echo Brian, so glad that you've joined us today.
Okay, thanks, Amy. And let's also ask Betsy Johnson to introduce herself quickly.
Hi, everybody. I'm Betsy Johnson. I wear the family/advocate hat on our team. Prior to joining TAC, I was at NAMI, Ohio for 10 years and worked on AOT implementation. So look forward to working with you all and helping you recruit some family advocates and invite them to sit at your tables.
Okay, thanks, Betsy. So I promise we're not going to turn this session into an infomercial for TAC. We really want to give you all an opportunity to get to know each other a little bit, since you're all going to be on this journey together, and give you a chance to meet some people who are just now coming to the end of it, and then we'll be keeping their AOT programs up and running now beyond the life of their grant, which is about to expire for that initial group. So before I introduce the AOT veterans who we've asked to take part in this today, I would like to just have everyone kind of introduce yourselves to the group. Just very quickly, I would like to go through all of the programs represented. We have a lot, so I don't want to, have everybody talk for more than 30 seconds or so, but just wanted to give you each an opportunity to introduce yourselves. And so I guess probably the most sensible way to do that is to go through the list of grantees and call on each program individually and hope we have somebody representing each program. I think we probably do. And I will start with Denver, Mental Health Center of Denver. Do we have somebody on the line from there?
Yes, that's me. My name's Katie Healy-Cox. I'm a social worker and have been with MHCD for about 6 years now. Don't know what other information you want from us, but
that
looking
works.
forward to started. Yeah.
Yeah, thank you so much, Katie. Great to have you. So the next program we have represented is in Boston. Do we have Sheila Casey or somebody from?
No, you have Judge Kathleen Coffey. Hi.
Oh, hi, Judge.
Hi. So I'm the project director. We're in an unusual situation because Massachusetts is one of 3 states that doesn't recognize AOT as an accepted treatment modality. So that's all I'm going to say at this point, except we're excited with this opportunity and hope to build on the good work that we have done through our mental health courts.
Thank you so much, Judge. And I have some thoughts about how we can work around that, which I'm really looking forward to getting into with you at some point. Let's see, do we have somebody from Communicare in Oxford, Mississippi?
A mask off. Hello, I'm Rachel Alcorn, and I'm the project director for the AOT program that we're starting here. And I have Jessica Griffin in here with me. I snuck her in. She is going to be the therapist for the program.
Terrific. Thanks, guys. Okay, Centerstone in Fort Myers, Florida.
Hi, my name is Adina Bridges. I'm the director of our South Florida practices here in Lee County. I also have the supervisor of our team and some other team members to just learn how we're gonna go forward. Thank you.
Thanks, Adina. Do we have someone from Calhoun County in Battle Creek, Michigan?
Yes, good afternoon. Melinda Holliday here, and Lakita Patterson, who is our project director.
Hi, guys.
Hey.
Sticking in Michigan, we have Genesee County in Flint.
Hi, I'm Julie Jones with Genesee Health System, and I'm joined today by our project director, Jennifer Kimmel.
Welcome to you. Okay, do we have someone from the Ozark Center in Joplin, Missouri?
We do. There are a number of us on the call. Hello, everyone. Okay. I'm Dr. Karen Lowenstein. I supervise the ACT and the ITCD teams here at Ozark Center, and we'll be heading up the Recovery Up program. We do have our director online and the director of accounting and our project data collection director. So those folks want to give a shout out as well.
Super. Thank you all for being here. Let's move on to the Pecan Valley Mental Health Center in Granbury, Texas.
Hi everyone, I'm Ashley Womack, Pecan Valley. I'm the Chief of Behavioral Health Services, and our project director is also on here with Harrington.
Great, thanks Ashley. Gastonia, North Carolina, Partners Behavioral Health Management.
Hi, I'm Judy Dahlstrom. I'm the project director, and I have with me Colleen Kinslow. She is a care coordinator manager. I have Todd Chambers with us. He is the clinical supervisor for the grant, as well as Dr. Williams, who is our research director.
Super. Thanks, Judy. Do we have someone from the Harris Center in Houston, Texas?
Yes, hi, I'm Mike Downey with the Harris Center, and I know Kena Lestavico, the project director, is also on the line with us.
Excellent. Thank you both. Sticking in Texas, do we have someone from Austin Travis County Integral Care in Austin, Travis County?
Hi, I'm Emily Stone. I'm the program manager, and we also have our practice administrator on here, Liz Baker.
Super. Thanks, guys. Moving to Mobile, Alabama, Alta Point Health Systems.
Hi, I'm Laurel Havard. I'm the project director for the AOT program, and we also have Danielle Knight and Ashley Knott on here, who are therapists and team leader for the program.
Great. Okay, and I think we have remaining, our friends in Kentucky, state of Kentucky.
Hi, this is Colleen Slusher. I'm the division director at the Department for Behavioral Health, Developmental, and Intellectual Disabilities in Kentucky. We have hired a project director, but she has not started yet. So we have Stephanie Craycraft and Dr. Tina Robbins on the call here from the department as well.
Excellent. Do we have someone from St. Tammany Parish in Covington, Louisiana?
Diane Dickey. I am the project director for the AOT program, or soon to be. I haven't actually been on board yet officially, so kind of resemble the last remark, but I'm glad to be looking forward to learning a lot.
Super. Thanks, Diane. And I think we have just one left, and that would be Springfield, Illinois, Southern Illinois University School of Med.
Hey, I'm Tracy Smith, and I am the director of the office under which the AOT will fall under. And then I have the program coordinator at this time sitting with us today.
Fantastic. Thank you all so much. This is super exciting to have you.
Did we hear from Wisconsin?
Oh, did I skip Milwaukee? I don't know how I let
You
that.
did. You forgot us. I don't know how you could. I assumed that Wisconsin comes last alphabetically. So
yeah, that must be it. Sorry.
Yes, that's okay. I'm Jennifer Whitwer from Milwaukee County Behavioral Health Division. Thanks so much for having us here. I also have Kaylin Dupree from our team. I'm the interim project director. Our project director will be onboarding in a few weeks here, and Kaylin will be the leader of our ACT team that we'll be developing as part of this project.
Great. Well, thank you all. Am I correct that SAMHSA has not actually done a full grantee meeting yet? So this is probably the first opportunity you all have had to see each other and get together? Yeah, thought so. Well, I'm sure that's going to change pretty soon. I imagine they're going to be calling you all together for an introductory session just to talk about the requirements of the grant and, orient you to that whole process. But one of the main things we wanted to do today was give you an opportunity to hear from some folks who have been grantees in the last round and are now getting to the end of the process, to just give you their own kind of basic thoughts on what they wish they had known when they had started this, that they learned along the way, maybe give you the benefit of that experience, and kind of share some thoughts on what their experience was in working with SAMHSA, and maybe they have a tip or two for you that will be useful. So we have three really great individuals who we've just loved working with these last 4 years. And let's start with our friend Jenny Bayer in Fort Worth.
I'm Jenny Bayer. I am the project director for AOT in Tarrant County, Texas, so that is Fort Worth. I want to give a shout out. I don't know how Brian missed Wisconsin because it's my home state and I'm kind of disappointed in him, so kudos to Milwaukee.
Plus I mispronounced your name, so I'm really batting zero.
Yeah, so Brian's kind of, 0 for 2 with me today. So I'm happy to be here, lend, especially for my fellow Texans who are starting their programs, kind of the knowledge we've learned from Brian and how to work within the Texas Mental Health Code throughout the startup of AOT. So.
Okay, thanks, Jenny. Do you want to just kind of launch right into saying a little bit about what you've kind of learned along the way? Yeah.
Sure, I can. So I think a few of our takeaways, and it's things I've heard from various centers, is that before we even applied for the grant, we were we got together with our probate court judges, our county hospital, and our DA's office to really make sure they are on board with this, because obviously without a hospital who has the clients that they refer to us, and without judges who are not willing to commit them into the program and do that black robe effect that Brian referred to, we don't have much of a program. So we are lucky enough that through various programs of mine, we have a very strong relationship with our county hospital, with the judges. So that was kind of a pretty easy piece, I think. I think where some of the part, and Brian was very helpful when we kind of first started the program, we reached out to him to have him come talk to our judges, our DAs, and our ad litem attorneys that would be representing the patients, to really go through some of the intricacies of AOT and at least in Texas, what the law includes and what it does not allow for. So I think that was something that was very helpful. And, you know, Brian could talk to them as attorney to attorney, which is always going to be better than me trying to explain something to them. And so I think at the beginning of the program, just the cohesiveness amongst the partners, along with that little added benefit from Brian for the ad litems and bringing them on, because at the end of the day, they're our biggest advocate with the clients to come into the program and kind of explain it to them. I think one of the lessons learned, for good or bad, is I think, in all honesty, we overstaffed. And I think it's kind of a thing we do at the agency in general. Anytime we get grant dollars, is we look at this pot of money and think, oh, we're going to fill every position that SAMHSA gives us. And what it has resulted in now is me having, because of various things, COVID, the courts still being shut down, in effect here, and those sorts of things, is that I now have 4 QMHP caseworkers who each have about 5 people on their caseloads. So it's been a little bit more difficult. So I think that's one of the things that was our error, is we went in gung-ho about putting all these positions in place that probably didn't need to happen. We have found a way to carry on the program. We are unfortunately going to have to do some staff redistribution amongst the agency, but we will carry on with the program in a little bit abbreviated version, which makes our judges extremely happy. I think I've lucked out in that I have 2 very good associate judges in the probate courts who really have loved the program. One of them will tell anyone who wants to hear him talk about it, how it's become the favorite part of his job that he does. So I think just, you know, the mantra we've used going into this, that my program manager is very, says every day, is just meeting the clients where they're at. Most of them, this is their first time where they've had a positive interaction with a judge, that they've had a caseworker who's actually cared enough about them to kind of take them under their wing and provide those wraparound services. So I think at the end of the day, it's a lot about that, just meeting them where they're at and figuring out what you can do to make their life a little bit better. The numbers will all come into play. What I've kind of coached my staff is, obviously, we need to hit targets, we need to hit certain things, but at the end of the day, if the client says they're happy and they feel like we've helped them accomplish what they wanted to accomplish, that's kind of my main goal for my staff. So.
Great. Jenny, could you say just a little bit about what impact you feel like the program has had on the mental health system in general in Tarrant County?
And actually, since I have a stat in front of me, because about an hour before this call, I talked to our county hospital about it. So one of the statistics, I think that was the biggest difference that we put in our end of the year report to SAMHSA this past year, was that the number of psychiatric inpatient visits for our AOT clients were reduced by 40%. So 6 months prior to them coming into AOT, there were 495 cumulative inpatient visits for them. after AOT had dropped to 297. We've had similar success stories, although I don't have them right at the top of my head, with jail recidivism. So just kind of keeping folks out of that looping cycle of, you know, going into the hospital, going to jail, sometimes going to both, jumping between the civil and the criminal side of things. So I think just the support that staff has been able to give them, you know, our judges kind of politely saying, I like you, but I don't ever want to see you again, kind of comments. I think it really helps. We, one of my staff members, part of his job, obviously we've shifted the judge's role to Zoom meeting, but they still meet with clients, you know, at least once a month. So one of my staff does up a report for the judges so they can praise them for things that are praiseworthy. If there's something that needs to be addressed, they can politely address it and kind of steer them back in the right direction again. So I think between my staff and the judges kind of monitoring and pushing along, I think we've had good results keeping people out of the hospital. And if they've gone into the hospital, getting them back out a little bit quicker than they normally would have been so they could still remain under the AOT commitment.
Yeah, no, it's been beautiful to watch, and I can't think of a better example of you know, the value that is added to an AOT program by having really caring, compassionate judges who really endeavor to get to know the people who come through the door and figure out what their life goals are and help them move towards it. So, you know, I wouldn't say having judges actively involved in that way is an absolute necessity to making AOT work, but boy, it sure helps. Obviously, you don't want judges to go in the other direction, but you know, because that can do harm. But you know, if you're lucky enough in your programs, I'd say to everybody to really have wonderful judicial partners, you know, we would love to help work with you to help them make the most of their role, as the two in Tarrant County have. So thanks a lot, Jenny. You know, before we move to the two other experienced AOT grantees that we have with us today, I am remiss, you know, I forgot to do something I wanted to do before we got to Jenny, which is ask you each a couple of poll questions. So let's go back to that because we really want to get a sense of where you all are with your development of your program and what you all have in mind about what your programs are going to look like. So Amy, do you want to kind of ask the questions that we have prepared? Give people a chance to respond. So that's there's the first one. How are you feeling about your grant? And excited seems to be the winner. That's good. I'm not seeing too many negative words in that cloud. I see an overwhelmed. Oh, I see an anxious. Okay. Perfectly reasonable, but mostly it seems like people are feeling really good about where things are and how you're progressing. So glad to hear that. Do you want to move to our next question, Amy? Yeah, so we're wondering now, and this kind of speaks to something Jenny was talking about, where you know, she feels like they kind of overhired. We're curious about what you all have in mind in terms of whether you're planning to integrate people into existing services or whether you were actually using the grant funds to build a dedicated team to serve people with AOT. And yeah, it looks like answer B is the overwhelming winner there. And, you know, that's not surprising given the fact that it's a, you know, fairly generous grant. And it's a logical thing to do with the money is to build a team of treatment professionals. But I would definitely, you know, keep Jenny's words in mind. And, you know, the other kind of thing I think to be wary of when you are doing AOT under a model where people are served by a dedicated team is, you know, you don't want to get to the point where a person's at the end of their court order and they don't want to leave the program because they don't want to be torn away from the treatment professionals who they have bonded with. people should have their AOT orders renewed, should stay in the program only to the extent there's a reason to think they're not ready to do it voluntarily. Intensive services should always continue because they're almost always going to still be needed when you get to the end of AOT. But the court order is really supposed to be a tool for people who can't do it voluntarily. And you don't want to create artificial incentives for people to stay in the program just because, it's going to mean having to connect with a whole new treatment team. So, I think that's something we can certainly work with you to avert. But I think the basic answer is to just kind of wean people gradually into that new kind of approach that's going to kind of take them beyond the court-ordered period.
Brian, can I add to that?
Yeah, please.
So in Tarrant County, what we've done, so an initial civil commitment in Texas is a 90-day commitment. Our judges have been somewhat, I don't want to say opposed, but for various reasons, we haven't done a lot of recommits here in Tarrant County. But our program is set up so that the first 90 days of treatment, they are getting ACT services from the QMHP and IMR services from a peer. And when they complete the 90 days of the intensive services at the AOT clinic, we are keeping them, if they so choose, they can get an additional 9 months of peer services from the AOT peers. And that gives them time to help them do a warm handoff and transition into a regular adult behavioral health clinic. If they meet the criteria to be like an ACT team type client, we would make the referral. But so we're kind of, even though our commitment period is relatively short, we're trying to keep them engaged, kind of just to do that warm handoff piece. And it seems to have worked well for us with the short nature of our commitments here in Texas. So.
Sure. Yeah, no, that makes tons of sense. Thank you. So let's turn the floor to our friend Karen Rogers from Livestream Behavioral Health in Lake and Sumter County, Florida. Karen?
Hi, I'm so glad to be here. This has been a great experience for us, and I just want to thank Brian again. I know we thank him a lot because you have added so much to making this a good experience for us, just with your expertise, and you're so easy to work with, and it's just been a really great partnership. A lot of the things that Jenny said are things that I would have said also, and will say. Hindsight is so wonderful that you wish you could have it starting out, but some of the things that were just touched on, I have my wheels turning about, well, geez, we could have done this instead to help us with the transitional piece. And when you write these proposals, you're talking about your sustainability plan, but it really is hard to know what that's going to look like when you have no idea what funding is going to be like 4 years later, and what kind of programs you're going to have. And it's just really hard to make those predictions. And we can have great ideas, but that doesn't necessarily mean they're going to come to pass. So, knowing what I know now, I think I would have structured a few things a little bit differently. But I will tell you, some of the challenges that we had. First of all, our orders went from 6-month orders to 90-day orders between the time that we wrote our proposal and were awarded the grant and started implementation. So that had an impact. It wasn't a challenge that we couldn't overcome. It wasn't that great of an impact, except that it messed up some of the other timing that we had planned for when we were choosing our evidence-based practices. And there again, you write these proposals, you choose evidence-based practices that you want to use, and then for us, one of the challenges that we had was that there wasn't enough information about one of the particular practices that we wanted to implement for us to have known that it really wouldn't work for us because it really required 2 years of people attending group. And, the program wasn't designed to be that.
What practice was that, Karen?
That was the cognitive training program. Can't think of the name of it.
Cognitive behavioral therapy, or CBT?
It was a particular program aimed at helping to do some cognitive retraining for people with psychotic illness.
Cognitive enhancement.
Cognitive enhancement, yes. We really thought, oh, that's going to be a great opportunity for our consumers. That's really something new that we wouldn't be able to have done without the kind of funds that were available, because these trainings, you know, these EBPs are very expensive, and in the end we hit a couple barriers. One, that the time frame to do it wouldn't have worked for us, and two, that the cost of the EBP wasn't something that that our CEO felt was an appropriate use of the funds in the end, because it was like $78,000, and even though we were able to negotiate some of that down, it still wasn't workable. So fortunately, you know, it didn't become an issue with SAMHSA, but you know, that's just one of those things that had I known a little bit more, I would have been a little bit different in my choices. But our other evidence-based practice that we employed has worked very well for us, and that's critical time intervention case management. So that's one thing. Actually two things. The fact that our time period for the Outpatient Baker Act, which is the law that we have in Florida, changed, and then that the EBPs that we really wanted to try out for size just weren't going to work for our program in the end. So being careful about that, and you know, I hope that none of you encounter similar problems. One of the things that was a benefit for us that some of your other programs, some of you might not have, is that we have an extremely comprehensive system of care, and we have a psychiatric hospital, a psychiatric crisis stabilization unit. So negotiating the AOT court orders happens in our own hospital, where the Baker Act hearings were already being held. And so we're negotiating with our own fellow employees in other programs, which doesn't always work, because as some of you may know, if you have a system of care like we do, that you can really get boxed into silos of services, and that you can end up with an inpatient outpatient split. You know, if anybody has had that experience, nod your head, maybe I'll see you. But this program has actually helped us to bridge some of those gaps and to tear down our silos, so to speak, because the way we designed it was that an AOT staff member would be in our hospital treatment team meeting every day in order to help identify people that might benefit from an AOT order. So having that person there, and then, you know, working and building relationships with our inpatient recovery specialists, discharge planners, the nursing staff, the hospital administrator, the inpatient psychiatrist, really helped us to break some of those silos down and improve relationships, inpatient to outpatient, for other programs, not just our AOT program. So beginning the engagement process under the, with the blessing of the inpatient staff, starting that process in the hospital when people are admitted, seeing who might be a good candidate for this program, and then working through that together, inpatient and outpatient, to get people in, you know, on the books for the hearings, and engaging them before they are discharged, because they're going to the hearing, their AOT staff is with them, their inpatient staff is with them both at the hearing. Those things have worked really, really well. Also, the partnerships between the court, we already had a partnership with the court because of the Baker Act hearings that we already were doing, but bringing the magistrate who oversees these hearings on board to do something different than what was being done prior to us having the grant. We were getting these weird orders, that's what I call them, weird orders that had nobody was really responsible for what happened next, and nobody really followed up. They kind of just fizzled out. And we were able to change that to a process that was actually, you know, in the statute, that we could use to our advantage and to the advantage of our consumers. So that improves our partnership with the courts as well, because the magistrate could eventually see that, oh, I haven't, when the person would come back in 3 months to renew their order if that was necessary, the magistrate could actually see the difference in how the person was functioning, how they presented, and could see, you know, in the history that that they were doing well and that they haven't been back to the hospital in 90 days, when maybe they'd had 3 admissions prior to their enrollment in the program. So that's another point I wanted to make. I think that you'll be happy with the ACT team models that you're using, because we kind of did a modified ACT team, not using the multidisciplinary approach, but not, I didn't feel compelled to do that as naming it an ACT team and following the fidelity, because of the different things that we were doing, one of which was the care management piece to help the bridging that inpatient to outpatient. But I do think that we know that wraparound services work for this population. So you'll have success from that point. It will be the judge's participation and that black robe effect that you're going to be trying to weed out a little bit. And we had a change of magistrates in the course of this as well, and went to a new magistrate who actually said in our meeting, I think you were there, Brian, that she wasn't necessarily warm and fuzzy. So she didn't know how much her presence, you know, the black robe effect was really going to have. But, you know, that really never really became an issue. And I believe that part of the black robe effect is that individuals who maybe previously never engaged with the treatment provider, never felt cared about, only experienced punitive interactions with the court system, were able to have a different experience. They were able to have an experience of, these people care about me. They're interested in my well-being, and they want to see me succeed, and maybe I'm willing to give it a chance too. So that black robe effect is really like a message from the community saying, you're important enough to us that we want to work with you, not just to keep you in the hospital, but to get you out of the hospital and to see how you're doing even when you're out of the hospital. So I think it's a tremendous message that if you have a culture in your organization, if you have a trauma-informed culture, a recovery-oriented culture, person-first culture, which, you know, we all say we do, but how well we actually live that can vary. You know, in our circuit, we have numerous providers, and, you know, we pride ourselves on really caring, you know, giving that caring engagement to our consumers. And of course, being a large system like we are, not every program is going to do that very, very well, but we want to, and we try to. So the engagement piece also includes the judicial system, and that judicial system is part of the community. I like the comment about, did we overstaff or understaff? I think we probably could have shaved off maybe one position, but I think that all of the positions that we have, maybe we would have converted one part of a case management position to another therapist, because in the end, I don't think we had enough therapist time available for the number of people we were serving. Also, that reminds me of the idea, you know, you're trying to determine a number to be served based upon what you think will make SAMHSA happy and how much you can really do with this money and how many staff you have times how many cases each person can handle. So it's really a guessing game. I think that we did extremely well in meeting our numbers, but I don't think we're going to hit our target by the end of things, and our target was 300. So looking at hindsight, maybe I would have still looked for that number, but maybe broke it out a little bit into what counts as a person being served, because that's how we're looking at it now as we're phasing out. We're not going to deliver the whole shebang anymore. We've had staff leave because we're phasing out, but we're still taking cases, and we will take cases, we will take orders up to the end, because we'll still have at least one person who is facilitating that and people who are still paid under our grant to make that happen. So I think one of the messages I'm trying to give is pay attention to the end at the beginning, and you know, lessons learned. If you seek similar grants in the future, that last piece of sustainability, I always hate that section, but I have come to understand that it means more than I initially thought it meant, and that I can, you know, write a proposal that will address the real sustainability issues, not just the financial sustainability, but the sustainability of what you're doing. And I feel really confident that we're going to continue to do these AOT orders, that we will continue to deliver high quality services, that they may not be provided by a specific team, but the service delivery will be monitored by a care coordinator or care manager to make sure that the people under the orders are getting what they need to get in order to be successful. So that's my commitment to the program, and I believe that we will be able to do that. And that's the model that we were doing in Florida, in Seminole County, that, you know, was the first Florida program that really was doing outpatient Baker Act orders, and was written about in the initial, I think, Brian, you were part of that, maybe you can speak to it, but in the initial reports on AOT. So I guess that's it. Any questions?
I'll tell you what, we're going to hold to the three
Okay. All right, good.
panelists till after we've heard from
Thank you. I hope I didn't take up too much time.
No, that was great. There was tons of
Get
super.
rolling, you know, I'm excited about it. It's been terrific.
Yeah, I'm sure many of us can relate to that because we're also passionate about this stuff. Tons of really useful stuff in there. I'm sure everyone felt that way. So let's hear from Maribel Tellez, our friend in Las Cruces, New Mexico, Doña Ana County.
Hello, I'm Mari. I'm so glad that everybody's here today. We are, just to kind of give you a little bit of background, we're in New Mexico, the southern part of New Mexico. So we have a lot of limited services. We're a border town. We went through a humongous shakeup with our government several years ago with our mental health providers, and we're still recovering from that. So when we applied for the AOT grant, it came at the perfect time for us to create a team to help clients who had not received services for several years because a lot of our agencies just closed down. But a couple of things that, you know, we learned, and Doña Ana County is the oversight for the grant. So we contract everything out. We contract with our service providers, we contract with our lawyers, our respondents attorney, the district attorney's office, with our housing navigator. So we had to do a lot of communication beforehand. Like the first person mentioned, we did a lot of planning beforehand, but even when you get the grant, it just seems like you're running at such speed that you can't catch up. So I would say that communication is just a huge thing. It's communication with your contractors, with your service providers. I've spent so much time trying to smooth over rifts between DA and service provider, or, you know, housing coordinator and our case managers, and it was not what I expected to have to do, but that really brought us together, and a lot of times it brought out questions that we had that we really weren't looking at the time, but we were able to focus on the client and doing what was best for the client. And as I was getting on board, everybody getting on board, we would really focus on the client. The first couple of years were very tough for us because we had a judge that didn't really believe in our program. We had service providers that weren't doing a whole lot of services. And so we kind of had to revamp everything. And we successfully lobbied for a new judge. We had a huge turnover of service providers. So we started basically with brand new people, and it was very scary at the time, but everybody was very supportive. Even all of our grant officers, we had a lot of communication with them. And one of the biggest things that really helped with us when that happened was bringing Brian in with the Treatment Advocacy Center. He actually had a really great meeting with all of the service providers for the entire day. We hashed out a lot of issues that we had. We asked a lot of questions that we just didn't know. And he was able to point us in the right direction, and that has helped us tremendously to stay on track and to provide the best services that we can for our clients. Let's see, the relationship with your judge is essential. Like I said, we successfully lobbied to get a new judge, and the judge that we have now is fantastic. She engages the clients, she creates relationships with them, she understands what the program is and what the program can do. And she really talks to not only the client, but the service providers, the attorneys, and everybody. So she really, it's become a team atmosphere. And I know that once the grant ends and I'm not going to have as much, interaction with the group, they're going to be able to sustain themselves with the judge. As long as we have that judge there, I think we're going to be okay. Let's see. I think another thing that was really important to know, is that your grant officer will help you when you have issues that come up. We did have some issues with assessments and reassessments with our clients, and our reassessment rate fell below 30%. And they want you to keep it between 60 and 70%. And we just did not know what to do. We did not know how to engage our clients to have them talk with our evaluator. And we reached out to the grant officer, and she really helped us to create a plan. And we implemented the plan, and we were able to get our reassessment rate up to 69%, which is really great. So don't be afraid to reach out to your grant officer. Don't be afraid to reach out to other people for help, because we also did reach out to an AOT team in New York, and he came down and he did a training with us too about ACT services, and that was great. So we were able to, a lot of things that I don't think you can do with just, normal funding. We were able to do a lot of different things with this grant funding. I would also say start early with the sustainability. We started thinking about sustainability in year 2, and we started having conversations with all kinds of different people about how we were going to sustain the program financially, because we had pretty big buy-in from a lot of our staff. They said that they wanted to continue the program, but we needed to financially look for sustainability measures where we could pay our attorney, and we could pay for housing services. And so we looked into different grants for that. We have applied for a couple of different grants that were able to extend some of the services that we have, like our housing services. And we were able to, really ask for people to cover financially. For example, our respondents attorney, he came from our competency hearings. He's the respondents attorney for our competency hearings. And so he does those. He's contracted with the Office of the Courts here in New Mexico, and we talked to them about the importance. We had our data, we had our evaluation done, and our evaluation reports, we were able to give that to them. And we think that they will cover it once November comes. And so that's, we've been working on that since year 2. But I do want to say that there, are some issues that come up with clients. We have our AOT court orders for 1 year, and we are able to offer services for all of our clients for 1 year, and we try and keep them in the program for the full year. Sometimes our clients really will need year 2, and we even have clients that really need year 3. And so we keep them in for as long as we need to keep them in. We do successfully discharge clients, and we do successfully have clients that are able to live independently and able to carry on. But you also have clients that come back to you. And so one of the things that we have asked our judge to do is at the end, when we have our discharge hearings, she takes a moment to talk to the client, and she tells them, we want you to know that we are here for you always. If you ever need anything in the future, you know where La Clinica is, that's our service provider. Please go over there and tell them that you want a hearing with the judge, and we will get you back in the program. And we have had one client that's actually done that. And then we also have clients that have been referred to us that have been in our program before, and when we discharged them, they decompensated, and it was best to get them back in the program. So it's all about the little successes that will help you get through the day-to-day stressors of AOT. But it's all in all, it's a wonderful program. Just to let you know, we've had a significant decrease in the number of days our participants spent in psychiatric hospitals. The average number of days spent in the hospital declined from 7 days at baseline to less than a full day. So that's significant for us. And so we really support it. We're really very much looking forward to just extending our services with the county and with all of our service providers here in Las Cruces.
Super. Thank you so much, Marianne. I think that last point is, to me, really the key to sustainability, right? Because if you're planning ahead to make the argument that this program, for whatever we spend on it, is a money saver, it is a no-brainer from a fiscal point of view, because we are avoiding the most expensive form of crisis response, which is hospital care. Mm-hmm. If you even can add on to that some data on how much you're helping people avoid arrest and incarceration, there could be some opportunity to get some funding from that system because of how much you are saving them in terms of having to house and prosecute people. So that's where the savings come from, and that's where really the funding at the end of the day should be available. And I think it's just so important to kind of have those relationships and make those silos from which the savings realized, really understand the value of what AOT has brought. And I also really appreciate the point you made about renewing orders when necessary. I think it's really important to emphasize, we're all here from different states, and the state laws vary widely in terms of how long the period of court order treatment is, ranging from 90 days at the low end to a year at the high end. But I just think it's important for everyone to understand that you don't want to think of AOT as just being about that initial period of commitment, that first order, and then you're done, because we have just so much data that tells us that a year seems to be the sweet spot for most people in terms of having gains that will not just be realized while the person's under AOT, but that's going to be sustainable when you go back and look at the person a year after they've graduated. It just takes longer than 90 days or even 6 months for those habits of treatment compliance and treatment adherence to really set in with a person. And so, we should really all be thinking in terms of renewing court orders for as long as it takes to get that person to the point where they now seem ready to do it independently. And that's a clinical determination that has to be made case by case. And, there's no failure in having to renew somebody if you have a 1-year commitment period. Look, there are folks whose baseline is such that they're not ever going to come to the point where they recognize, they see the value in treatment, and they'll tell you with that exit interview, that evaluation at the end of the period, I'm only doing this because the judge says I have to. And that's someone who you want to renew. And that's not a failure on anyone's part. That's a success that you're managing to keep that person stable in the community. But that's not going to be the norm. You know, most people will, after about a year, be ready to move to a voluntary treatment model. It's just a case-by-case determination. Well, thank you all, the three of you who presented, much appreciated. I'd like to turn in the time we have left. We have about half an hour, and I'd like to spend most of that just kind of opening the floor and giving folks a chance to ask questions of the 2016 grantees we have, or of us on the tax staff, or even of each other. If you want to, you know, just share about whatever you all are struggling with right now as you work to ramp your programs up. So I think we probably can try and make this work just if someone just wants to speak. And, you know, if we find that we're having a lot of people talking over each other, maybe we'll move to use the chat box to let us know you want to ask a question. But let's at least give it a shot and see if anybody wants to ask anything or say anything.
This is Colleen, and I'm in, our grant is kind of based out of the Gaston, North Carolina area, and in multiple counties that we'll be covering. But I have a question about the outpatient commitment and the potential for subsequent involuntary commitments. Because in North Carolina, if someone's on an outpatient commitment and then they're involuntarily committed, it cancels out the current outpatient commitment.
Okay, so Colleen, when you say involuntary commitment, you're talking about a hospital commitment there, right? Because, but
Yes.
just clear to, you know, just because terminology is different from state to state, outpatient commitment is also involuntary, you know, even though most people do enter the program willingly, right? But so you're saying, you're asking about whether a hospital commitment trumps the outpatient commitment.
Well, it does in North Carolina.
Right.
And so I'm just wondering if anybody else has that experience in their state and how you've managed that.
Okay, do any of our 2016 grantees want to speak to that? If not, I'm happy to. Have you all dealt with that at all, where people who are under outpatient commitments have their become inpatient committees during the period?
We have done some modifications from outpatient to inpatient. Basically, we let the hospital decide if they come back in. It's just something as simple as maybe they need a med tweak. We just kind of keep them there with their legal status as being on that AOT commitment, and then they come back out into the program. If the hospital determines it's something that's not going to be fixed just within a couple days and maybe a med change, then we do go to the probate court judges, and one of my folks, who is kind of our community liaison between the hospital and the judges, does all of the modification paperwork, and we basically put the kibosh on the outpatient order and just have the hospital proceed with doing what they normally would do for a temporary inpatient mental health commitment.
Yeah.
But just by nature of them going to the hospital, it doesn't necessarily cancel it out for us.
Right. Going to the hospital, either voluntarily or even on a short-term hold, should not cancel out the outpatient order. But when it comes time to move that person to an inpatient order, I think Jenny, you know, the word she uses is modification, and that's really what it has to come down to. You've got to modify the existing order, basically turn it into an inpatient commitment. You can't have two civil commitments apply to the person at the same time. And what that means is that when the person's ready to come out of the hospital, there's going to be a need to modify it again, turn it back into an outpatient commitment, because that previous outpatient commitment will not still be in effect because it has been modified into an inpatient order. But I think that's really the key. Yeah.
What I'm hearing then is that we're going to want to try, and that's another level of education that we want to try to educate not just our providers about, but our family members potentially, that they would request a modification of an order rather than just going straight to the magistrate and saying, I want to put my loved one in the hospital because they're a danger to self or others.
Yeah, I think that's right. I think that's right. Or, you know, even if there's an opportunity to appear at the hearing, you know, if they have filed basically the wrong thing and there's not, you have an opportunity to come into court, appear at that hearing and explain to the judge what's really going on.
Gotcha.
Yeah, that
makes sense.
The way
Yeah.
And,
okay.
And I think it's key that whoever's providing the treatment maintain that treatment engagement even in the hospital. So you don't want to have to transfer somebody off your team because they're no longer on AOT. You want to keep them on your team.
Right. You know, another situation that's likely to come up is that somebody who you have under AOT winds up in jail. You know, there might be a need to, you certainly don't need at that point to modify the order in terms of replacing it with another kind of order because you know, they're in jail, and they're not going to go under an inpatient order. But you might want to modify the requirements. Obviously, they can, you know, the part of the court order that's on you to deliver certain services is not going to be possible to fulfill while the person is in jail. But so you may need a modification of the order just in terms of relaxing the requirements to deliver certain services that are no longer possible. But you know, you still want to have that order in effect in a modified form so that when the person comes out, you can resume it without having to refile.
Can I just add, we try and really have constant communication with our detention centers and with our inpatient hospitals so that we know that if somebody has been on an AOT order and then they either go into the hospital or go into the detention center, then when they're released, they'll call us and they'll let us know so that we can get a peer support to pick them up, or we can meet them somewhere. So we know that we can start with services again right away. And we also have peer support that go into the detention center that will meet with them while they're incarcerated.
Great stuff.
One of the things that we experienced in the beginning, not so much later, but when people were not complying, adhering, whichever word you want to use, when they're not following what they're supposed to be doing according to the order and according to the treatment plan that the team, that they devised with the team they participated in, you know, in the past, everyone would say, outpatient orders don't have any teeth. Those are the words that are used. And you have to re-Baker Act them to get them back in the hospital if they're not doing well. So what's the point? So what we were able to do is, if they were not, you know, participating as they were required to participate, and there were concerns about their well-being, the team would complete an ex parte order, which the difference between that and, you know, just doing another involuntary inpatient commitment would be that the provider didn't necessarily have had to have laid eyes on the person within 24 hours. They're going by report. They're asking the court to have the person picked up and re-hospitalized. So once we started to do that, then the next challenge we had was that the reason that we brought them back inpatient was because obviously outpatient was no longer the least restrictive level of care needed. And so, you know, technically they needed to go back inpatient, but when the doctor evaluated them, the doctor would say, well, they don't really need to be Baker Acted. They don't need an inpatient Baker Act. They don't meet the criteria. So then we would have this struggle of the doctor wanting to just release them immediately, whereas the whole point of this was to use the order to reinforce with the person that, no, we're serious here. This is a court order, and if you're not following the order, then we go to court and we say, this person isn't following the order, they can't do outpatient, they've demonstrated they can't do outpatient, they need to go back inpatient. So eventually we got the physician who saw most of our individuals inpatient to understand the whole point of this and to not get into a struggle with the program about they don't need to be inpatient. Right, maybe not, but they're not following their outpatient order. And this is where they have to go back so they can be brought back to the magistrate again in the Baker Act court and report, so we can report to the magistrate, this isn't working. And so it gives you the opportunity to show the person the black robe effect, so to speak, the importance that this is an order. This, even though you said you wanted to be here, it's still not voluntary, it's involuntary. And, you know, again, that building the relationship inpatient to outpatient, building the relationship with the Baker Act court, in our case, Baker Act, with the magistrate, whoever's involved, so that everybody gets to see this is how it can work. So it will take you a few times probably to get all of that to work the way you want it. Especially, it may be more challenging if the hospital is not part of your own system. So imagine for us, it is part of our own system, and it was still a struggle for us. So just as a warning, be ready for that. Understand what your law is going to allow you to do, and make sure that everybody who's going to be involved, if you do readmit that person, understands what the point of this admission is. Sometimes it's they really needed to be back inpatient, but sometimes it was they really needed to understand this outpatient order and what it means and how everybody's responsible, including your program. You know, you're responsible for the order, in the order too, to deliver the services and monitoring that you said you were going to deliver on behalf of the court.
Yeah, thanks, Karen. And you know what Karen is describing is it's a universal struggle of new AOT programs. It's something I've worked with so many on, and you know, anticipate working with many of you to really solve it. You know, it's how you make that court order meaningful in terms of what the consequences are for violating it. You know, we emphasize all the time that there is no punishment ever associated with violating the AOT court order. Most of your states say you can't hold someone in contempt of court for that, even where that's not in the law. We strongly, strongly urge that that never be the way you make the order enforceable. But, you know, that pickup, that short-term hold followed by an appearance before the judge, it's not a lot of teeth. It's all we have and it's all we need. But we have to make that piece work for every program, or else the message filters to the participants that, you know, this is just a piece of paper and program can fall apart.
And one of the things I just thought of as Karen was speaking to is, I would say plan ahead for certain forms you might need if you guys don't have them in place already. Yeah. One of the things, most of our forms we could modify with the courts pretty easily, but one that we've had to kind of brainstorm on here recently is we've had a couple folks that very shortly into the program, from our side, we've had to remove them from the program. And in Texas, you have a 30-day window that you can set aside the order. And so working with our judges, I mean, every random scenario you think isn't going to happen probably will at some point. So I would say as much as you can anticipate for those just weird forms and who the person is that's going to be, like in our case, my community liaison files all of the forms, whether it's the modification, the order to set aside the hearing, all of those things. So kind of who's the gatekeeper of those forms, and working with the DA's office to make sure they're legally sound.
Yeah, so. And if forms need to be developed, the good news, we at TAC have a huge database of them. So we have lots of templates for you to copy. Anyone else want to ask anything of our panel or of each other? Raise any concerns, and maybe something about working with Samson, maintaining that relationship? It's a good opportunity to talk about that bluntly and frankly.
I do want to, sorry, this is Melinda from Summit Point in Michigan. I'm curious, we're looking at evidence-based practices. Curious from a group standpoint, what groups did you find most beneficial to participants?
What specific?
Like evidence-based groups that were run in a group format.
I think ours are mostly the IMR services through the peers. just doing those well, again, previously in person, now on GoToMeeting, but just the peers, having that ability to get kind of down and dirty with the folks in the program, you know, and provide those IMR services to them. I think our peer groups have been the biggest success in that curriculum that they follow, has been very helpful for us.
This is a good point for me to bring up the challenges we have with our folks that have co-occurring substance use disorders. This can be another challenge to your program because, as you know, there will be people in your inpatient psychiatric facilities who have co-occurring disorders and who may have psychotic disorders in addition to or because of. And weeding them out in terms of, is this truly a person, you know, knowing enough about the person's history, is this truly, does this person truly have a mental illness of the type that can benefit from being in this program? Or is this really some psychosis related to years of substance use and, you know, homelessness and all the other things that go with it? And what we found was that the folks that were most likely to have difficulty succeeding in our program were the individuals who really had higher substance use. If you think of these as, you know, high substance use, high mental illness, high substance use, low mental illness. If they were low mental illness, high substance use, they shouldn't be in your program, unless you really designed it to be that way, and then you're gonna maybe have some conflicts with your orders. We also have an outpatient order, we have substance use order under the Marchman Act for involuntary evaluation and involuntary treatment when that's strictly the problem. But just as a caution to you, be careful in your screening process. These may be individuals who have a lot of recidivism to psychiatric admission, but you know, that's really not what they need. What they really need is residential substance use treatment. So in terms of groups, if you're admitting people, that you will be admitting people that have high mental health and maybe moderate to low substance use, maybe groups that are targeted to educating about the substance use issues, educating about, you know, medications and substance use and how they're, you know, going to be working against each other, harm reduction strategies. You know, you're picking your battles sometimes with your consumers, but you don't want to create a battle of who gets admitted. That's not going to work your program, and then you're going to have people dropping out, you know, running off. Nobody knows where they are, and it just, you know, this isn't about mental illness. This is about mental illness as the primary disorder. And just to let you know, that was a challenge for us. And we learned along the way to be more careful in how we screened and who we admitted to the program, who we advocated for to have orders with the court. And if we did admit someone that really needed stronger substance use treatment focus, then we referred them out.
Okay. Thank you.
Yeah, no, I think that's a really important point. And, you know, primary diagnosis there being the key words. It's not to say that there aren't lots of people with co-occurring disorders who are going to benefit from AOT. You know, I think the thing to keep in mind is that we have this enormous evidence base that AOT is effective in helping people, all kinds of people, engage with their mental health treatment better than they had before. We don't have an evidence base to suggest that it's going to, that the black robe effect itself is going to motivate people to abstain from some substance that they're addicted to. That in itself is probably not a realistic expectation of AOT. But of course, if you can get people who with co-occurring disorders to do better with their mental health treatment, then that's going to address a lot of people's substance abuse issues, right? It's going to reduce their impetus to self-medicate. So, you know, there is a real place for AOT for people with co-occurring disorders. But, you know, yeah, you want to add something? I know Amy has a lot of thoughts on the subject as well.
I have a lot of thoughts, but that being said, at our AOT conference last fall, Dr. Anita Everett spoke, and she spoke about some of the data from the current grantees, the soon-to-be graduating grantees, and how AOT did reduce substance use in their co-occurring participants. So, yeah, I never want to discourage someone from being considered because they have an addiction. And exactly what Karen said is that if addiction, and you won't know, you can't tell right off the bat. It's hard to figure out which is primary, but for those where you know that addiction is primary, AOT, I totally agree. AOT is not the right place for them.
Yeah. I think we probably have time for one more question or comment if someone wants to make one. No?
This is Colleen again. Is anybody working in combination with persons who are not insured or an indigent population and that has Medicaid? And what barriers have you come against with that, if any? Any lessons learned?
Mari, do you have anything to speak to that?
We work with clients that do not have insurance, do everything. We have a really great indigent program that the county funds, and so we're able to reimburse our service providers when something like that comes up. We really haven't had issues that I know of because we have a great indigent fund.
Yeah, I think my concerns are more about, like, we have plans to help people in getting their benefits. And so if we're paying with indigent funds and then they get Medicaid, what kind of complications have arose with that?
I don't think I can answer that. I don't think I don't work on that side of this, the service provider, but I know we do that. And I know our service provider does do that. And they haven't mentioned any issues to me or not anything that's big enough to bring up to us.
So I'm just curious what your concerns are, Colleen, because I think that's a pretty common thing for people who are indigent to get approved for Medicaid.
Just that where the monies are coming from, and does that get then, if it came out of an indigent pool and then you can retro bill Medicaid, do you put that money back into the grant?
You know what? That is a question for your GM, your grant management officer.
Yeah. Yeah, that's a SAMHSA question. I agree.
Mm-hmm. I would agree. Also, Colleen, are you all going to be using the SOAR process to
Yes.
help people get their benefits? Great. That's
Yes.
great.
Okay, super. So in the few minutes we have left, I would like to just indulge, if you indulge me for a minute, I'd like to tell you a little bit about what I think TAC can offer all of you in terms of making these programs successful and getting off the ground. We have a number of ways in which we engage with folks who are doing AOT, both through the SAMHSA grant program and beyond. We have lots of AOT programs around the country we have worked with who have not been involved in this grant program at all. And a couple of the things that we will hope you'll avail yourselves of are completely readily available to you right now. One of them is our AOT Learning Network, which we recently launched, which you've probably seen a couple of emails from me about that. Cannot urge you enough to, if you haven't already, to please have all the staff, all the stakeholders, everybody with any role whatsoever in the AOT programs you're building enrolled in our AOT Learning Network. It's just a matter of, we'll send the link, we'll put it in the chat box, and hopefully send it again after this meeting. It's just a matter of signing up for it and telling us what your role in AOT is. And it's an opportunity to have these kinds of conversations on a regular basis with people who have been doing AOT for a long time and who are, really passionate about it and want to help you in any way they can. So it's just really about making sure that no AOT program feels like it's an island, that we all have the support of everyone who's been part of this community that we've been building for a few years now. And we'd love to have you sign up for that and be part of the webinars that we do and the profession-specific chats that we do, and also just kind of receive the information and updates that we're putting out constantly through that. So that's one quick, easy thing that we hope you'll just push out to everybody who you hire, everybody who's going to have a role in this at all, get them on board for our network. Another thing that, I really can't stress enough the value of is to take a look at our AOT learning modules, and again, have all your staff as they come on board as part of the onboarding process, go through those modules. That's a 4-hour or so self-guided interactive course that we have developed on the basics of AOT, explaining what it is, what it seeks to accomplish, and the building blocks of creating a program and sustaining it over time, and some tips that we've gleaned from all the programs we've worked with about how to maximize results. That is available through a website called SMI Advisor. It's a part of an APA project that we were funded to create a piece of, and our piece of these AOT learning modules. If you go to smiadvisor.com/AOT, we'll put that in the chat box too. You can sign up for access to the learning modules. And again, I just think there's great value in having everybody who's going to be a part of your program, including your judges, take a look at them. And there's an opportunity to skip certain modules that may speak to you. I mean, they're written for a very broad audience. So if certain modules are addressing things that you know about because it's your own professional expertise, you can jump right past them, move on. But I think that, it's just a great learning opportunity, and will really help you if you work with us as a TA provider. If we come in and do a training of your staff, to have had folks already view the modules will allow us to start at a more advanced point and really get into greater depth. Which leads me to the third way that I hope we're going to have an opportunity to work with you, is as a direct partner, as providing direct technical assistance to each of your programs, as we have done with all of the 2016 grantees. And we have actually changed the way we are making that available. I think we're really excited to say that we have developed a fixed pricing model where we're asking just for the price of $5,000. We will be basically available to you for the entire first year of the grant. We can, can renew after that as needed. But whatever TA needs you that first year, we will provide. Whatever form that takes, we're available to handle. And so that could be, and I think in most cases will involve doing trainings of your staff, where we come in and present to a large group of people on AOT and what to expect and how this is going to work. But it's also going to be that ongoing opportunity to work through all the kinks that will inevitably develop and help you kind of develop policies and procedures and help you do the evaluation piece and actually collect data even beyond what SAMHSA is requiring. That will allow you to make really good decisions about what is and isn't working about your program. We can help you with developing materials, public-facing materials that you want to put out to help promote your program and make those connections in the community and involve families more in the program. All kinds of ways, and we can talk more offline about that, we want to be available to you as a TA partner. And so rather than kind of, as we did with the last grantees, kind of bill as we go, we think it's going to just be easier for everybody, and will more than pay off, I think, for everybody to just, say for $5,000, here's what we can do. Now, for most of you, I think that's going to, require finding some funds in your current grant budget. Having talked to SAMHSA, I know that they are very amenable to that. They strongly are going to encourage every grantee to receive TA. It's something they themselves are not able to provide. And so if that is not something you've already budgeted for, it's going to be, I think, a pretty easy lift to work with SAMHSA to, direct funds for that purpose. So we'll be in touch with all of you further about that, and hope that that's an opportunity we can all have to work together.
One more thing about that that offer, the $5,000 does cover in-person training. If that's something that we're able to do at some time in the future, it will not cover travel costs. So if you want to bring us into your location, we're happy to come, but you'd need to pay for all travel fees.
Right. Which, realistically in the first year is probably not going to be an issue given where we are as a country right now. It doesn't seem like we're traveling anytime soon, but we sure hope to do that at some point and get out and see all your programs in action once they are, in that year 2 point where they're doing great things. So, one other thing I would like to just briefly mention, and that's that I have been contacted by a filmmaker by the name of Ken Rosenberg. Some of you may be aware of his film Bedlam, which aired on PBS recently, which was, really, I think, the best thing that's ever been done in exposing a lot of the dysfunction in public mental health system. He has received funding for his next film to do something on the intersection between the legal system and mental health system, and he wants to feature AOT as a kind of a prime piece of that, and is very interested in seeing an AOT program built from the ground up. So, he is going to be looking for an opportunity to connect with a program that would be interested in having his kind of small film crew observe the things that are happening to get an AOT program, and maybe those baby steps and that initial ramp up to the point where you're doing hearings. I think that's all something he would love to be able to capture and feature in his film. So if there are any of the programs on the line today that have any interest in that would be interested in at least talking to Ken about the possibility of him coming in to observe, just, probably the initial commitment would just be to have a conversation about about what that would entail. If there's anyone with any interest in that, please let me know about that, and I'll probably reach out to you again about it. But, could be a cool thing. It's an opportunity to help us amplify the importance of this concept and get the word out there. And I think we're at 4:30, so that is our time. And I thank you all so much. I hope this has been valuable for you. It's been great for me to see all the faces of the folks that we've been emailing with, and get you all to see each other. So we'll continue to be in touch and really hope to be working with you all. And
thank you.
Part of this today.
Thank you.
Thank you.
Take care, everybody.
Ms. Rogers, I see you're still on the line. I had a question about how many staff you had hired for your team to serve 300.
You're muted, Karen.
I think by now you'd get that mute thing down, but so it depends on how you're structuring your program. So 300 people over the course of 4 years. And, how many do you intend to serve per year, and what kind of services are you delivering? If you're delivering case management services as well, then you want to think about intensive case management is going to have maybe, maximum caseload to be 15. How long are you anticipating people to be in the program? Then that's going to help you determine, what the turnover of the caseload will be during that period of time as well. So it really depends on what you're intending to deliver service-wise with your team, and what staff to participant ratios you need to have for those particular services. Does that help, Colleen? It's not a definite answer of a number, but
Yes.
I hope that helps.
Yeah, it does. Thank you.
You're
welcome. I think we're on target. I just heard, I don't remember if it was you or somebody else who had said that they had overstaffed.
Right,
and
I said that I might have.
What does that mean?
Yeah, and I might have staffed a little bit differently to give more therapist availability. So, yeah, good luck. I'm excited for you.
Yes, thank
Thanks,
you.
Kelly.
I appreciate this. This was very helpful today.
And you're
I'm so
welcome,
glad.
Brian. Share my email address if you want to. That's fine.
We'll do
I'd be
that.
happy to hear from you. Okay?
All right. Thank you, guys.
Bye, guys.
Thanks.
Thank you.